أرحب بالدكتورة يمامة، أهلا وسهلا بك معنا في أسبوع المحاكاة اللي يقيم من جمعية المحاكاة السعودية. ومرحبا بك معنا البروجرامز. أستاذة يمامة، دكتورة يمامة دكتور معتمد وعضو وهي تدريس في كلية الطب، تخصص أمراض الكلى، جامعة محمد الخامس، الرباط، المغرب. حياك الله معنا وأهلا وسهلا بك. ومرحبا بك في اللقاء اللي تعرفين عليه عن سيناريوهات المحاكاة. مرحبا بك وأهلا وسهلا بك.
السلام عليكم ورحمة الله تعالى وبركاته. أنا متشرفة بحضوري معكم اليوم بمناسبة أسبوع المحاكاة. هل أبدأ؟ سوري.
اتفضلي دكتورة يمام.
شكرا. السلام عليكم ورحمة الله تعالى وبركاته. بسم الله الرحمن الرحيم. It's a great honor and it's a great pleasure to be with you and to be invited by the Saudi Society for Simulation in Healthcare to present this lecture titled Constructing Healthcare Simulation Scenarios. Healthcare educators, as you know, and simulations use various simulation-based learning experiences to meet learners' needs. The development and integration of simulation scenarios is a thoughtful and systematic journey. Using best practices and evidence-based approaches provides a solid platform for this valuable teaching technique. Designing a simulation takes time and thought. I hope I will not, by this lecture, cover all the aspects of designing scenario simulation, but I hope that by the end of this session, we will have I will try to highlight the biggest criteria for designing well-designed simulation scenario. Let's start by the definition. Scenario in the drama, originally used in the drama, is the detailed sequence plan, description of all the scenes, or description of a pre-established sequence of an action or a role or an activity. In healthcare education, it shares with the drama the fact that it describes sequences of events, but in this case, it's to achieve educational goals through experiential learning. It requires immersing students in a patient care setting that mimics the actual environment with sufficient realism to allow learners to suspend disbelief. For reminders, healthcare simulation scenario is split in 3 stages: pre-briefing, simulation scenario itself, and debriefing. There is missing slides, but it's okay. We will start by the why of Simon Sinek. Why writing scenarios? Simulation scenarios are designed to educate in one hand and to assess in the other hand. To educate by helping learners to self-identify and fill gaps in their technical performance, theoretical knowledge of procedural competencies, and non-technical competencies, teamwork, communication challenges, and other soft skills. These scenarios are created for students to learn in a safe environment to reach the ultimate goal of improving clinical practice and patient safety. But how will we construct these simulation scenarios? There is lots of, I'm sorry, but it's not the good presentation. So I will suspend this presentation to have the good one. Sorry. Is it fine now? Can I proceed?
Yes.
As reminders, the healthcare simulation scenario is split into 3 stages: pre-briefing, simulation scenario, and debriefing. For the pre-brief is a crucial component of practical simulation experience. It introduces learners to the simulation concept. It orients them to the simulation environment, equipment, and embedded participants. It allows to disclose the purpose of the simulation scenario upfront. Is it for education or for assessment? The debriefing at the end of the scenario is undertaken to create a trusting environment where participants are comfortable in exploring their thinking processes, their actions, the actions they have taken or not taken, and the gaps in their knowledge and skills, and reflecting on the events of the scenario and how they relate to their future clinical practice. Debriefing is allowing, we must allow enough time for the briefing sessions because it is the most important aspect of the simulation. Simulation without debriefing solidifies rather than corrects mistakes and misconceptions. And I love this citation: when debriefing, the time belongs to learners, and it's time to facilitators to listen, not to teach. And it's a challenge for educators because we are used to talk for teaching and not to listen. So it's very important to give enough time for the briefing sessions. Alors, while writing scenarios, we said that earlier, to educate, to assess, and ultimately to improve clinical practice and patient safety. How can we design the scenario, the simulation scenario? First, we have to make a literature review, and I did it. And here some works from simulationists who, for some, they propose guidelines or propose the criteria to write simulation scenarios. And after this literature review, I came with 13 criteria, which seems important and for writing a scenario. The first one, the writing should be directed by an educator trained in simulation. And the second one is the needs assessment is crucial as first step. Then the scenario should be based on valid learning objectives, which are based themselves on the needs assessment. The complexity of the scenario should be adapted to the learners The material and human resources must be anticipated. The modality of simulation must be aligned with the learning objectives. And each scenario must include a briefing session and progressive sequence events with the fidelity to be determined depending on the scenario. And the facilitation must be documented. The scenario must include the briefing session with enough time, as we said earlier. And the two last items, and not the least important, are the evaluation of the learner and the session, and the pilot testing of the simulation before its implementation. For the first criteria, who will design the scenario? The scenarios must be designed by the simulation designers as well the content experts. The simulation designers, in one hand, should have formal or informal training to be competent in best practices in simulation education, in simulation pedagogy and practices, and be knowledgeable of ethical standards of simulation-based experiences. Content experts, in the other hand, should have a general knowledge of simulation and scenario design principles and debriefing methods and evaluation approaches. Here some methods suggested for developing competency, but are not limited to. The best one is the formal coursework or certification. We join in professional simulation organizations, incorporating the healthcare simulation standards of best practice, simulation conference attendance or workshops, continuing education offerings, focusing on pedagogy. The second criterion is the needs assessment. It's crucial to provide the evidence of the need for constructing simulation-based education. The needs assessment may include analysis of a lot of sources, an examination of knowledge, skills, attitudes, and or behaviors of individuals, underlying causes of cancer, for example, high mortality in the department, organizational initiative, surveys of stakeholders, learners, clinicians, or educators, outcome data, for example, from certification or licensure exams, from previous simulation-based experiences, from patient safety data. We have to know the standards from certifying bodies, rules or regulations, practice guidelines, the quality improvement programs, and patient safety goals. The use of the needs assessment results to guiding the development of broad objective for the simulation, which in turn directs the designers in the development of simulation-specific learning objectives. Identification of the simulation-specific learning objective may assist designers to create innovative and interactive experiences that aim to enhance curriculum in the classroom and or clinical areas, provide opportunities for standardized clinical experiences, address competencies, improve quality of care and patient safety, promote readiness for clinical practice. The learning objective must be congruent with institutional curriculum and program outcomes, and must integrate best practices. They are used to help tailor learning content and serve as guide to the debriefing. They are achieving during the simulation experience and or during the debriefing. The learning objective must address the three domains of learning: cognitive, psychomotor, and affective. So we have two categories of competencies, technical competencies and non-technical skills. Technical competencies are represented by theoretical competencies, medical knowledge, and technical as procedural skills and medical interventions. To construct specific objectives, the use of the SMART template is preferable when it is possible. SMART, so S for specific, to answer two questions. What do we need to achieve? Who needs to be involved? For the M, measurable. How can you measure progress, and how can we know if we met our goal? Achievable. Can the learners meet the goals through simulation? Or are they relevant? What is their impact? Timely. Can the learner objective be met in the time allotted? We can distinguish broad and specific objectives to address identified needs. Broad objectives reflect the purpose of the simulation-based experience and are related to organizational goals. On the other hand, specific objectives are related to participant performance measures. Together, they provide a blueprint for the simulation. During the design phase, we have to determine which objectives will or will not be available to the participants before the experience. For example, objectives that provide general information and context for the learner should be disclosed. For example, providing care of a post-operative patient or care for a patient with heart failure. However, participant performance measures should not be disclosed until the debriefing session. For example, specific critical actions. Objective disclosure will be determined by the overall purpose of the simulation-based experience. After we have identified the needs assessment and the learning objectives, we have to know who are our targeted learners. We have to know at which category from which category they are. Are there nurses, physicians, dentists, pharmacists, physiotherapists? And we must specify the interdisciplinary and/or the interprofessional nature of the team. We have to identify their background, competencies, knowledge, skills. Are they in their initial or continuing in training? And what about their previous experience with simulation? The fifth criterion is the equipment available. And here we have to make a compromise between what we would like to do and what is possible to do. What are the simulators we have? Do we have mannequin? What is the level of fidelity, of technicity? Are there props, moulage for standardized patients? What is the environment? Is it suitable for better immersion? What is the space allocated? What is the office? Are there office equipment, audio-visual equipment, material, monitor, disposable materials? And now we have all the information, the previous information, we can choose the modality of the simulation-based experience. The modalities can include simulated clinical immersion, computer-based simulation, virtual reality, procedural simulation, and or hybrid simulation. These modalities are achieved using standardized patients, mannequins, haptic devices, avatars, partial task trainers. The modality provides the structure and the process. Selecting the modality of DSBE is based on the needs assessment, learning objectives. The modality must align with the objectives. The resources available, the targeted learners, appropriate for the targeted learners, and the purpose of DSBA to provide a formative or summative encounter. And we will start with the scenario itself. The first section of the scenario itself is the briefing. It is an integral part of the simulation session. The briefing sets the stage for the scenario by identifying participants' expectations and establishing a psychological safe learning environment of integrity, trust, and respect, and by establishment of ground rules and a fiction contract. The briefing must be structured, planned for consistency, and completed immediately before the scenario. Preparation may include the following: information regarding codes of conduct, confidentiality, and expectations. They may include activities related to the content, reading assignments, or answering simulation-specific questions, or watching preparatory audiovisual, completing a pretest, and so forth. The briefing should include orientation of the participant to a basic understanding of the simulation-based experience concepts, to the space, the equipment, the simulator, the broad and specific objectives, the expectation, the method of evaluation, the roles of the participant, the facilitator, the standardized patients. They had to be informed about time allotment, patient situation, and its limitations. A written or recorded briefing plan standardizes the process and content for each scenario. After the briefing, we enter in the heart of our subject, the structure of the scenario itself. All the simulation-based experiences include a starting point, activities, and an end point. The starting point represents the initial circumstances of the patient or situation when the participants start their engagement in the scenario. The structured activities is about the simulated case and or psychomotor skill teaching or evaluation. The end point is the stage at which the SBE is expected to end, usually when desired learning outcomes have been demonstrated, when time is exhausted, or when the scenario can proceed no further. A scenario includes four sessions: a situation and backstory, script, clinical progression and cues, critical actions, performance measures. The situation and backstories provide a realistic starting point from which the structured activity begins. The full picture of this context may be given verbally to the participant, found in the patient's file, or be revealed if requested through adequate inquiry on the part of participants. The script is developed for consistency and standardization to increase scenario repeatability and reliability. Variation from the planned variation from the planned dialogue may add distractions that could interfere with learning objectives and affect the validity and or reliability of the scenario, especially when the activity is expected to be run with consecutive group of learners, and we want a certain repeatability. And when it is an assessment, it is in the context of an assessment. The clinical progression and cues provide a framework for the advancing of the scenario in response to learners' actions. The cues are used to guide the learner, to drive decision-making and action, to refocus participants when they stray from the intended objectives. Cues can be delivered to participants in a variety of ways, including verbally through the patients, provider, or embedded participants, visually through changes in vital sign on a monitor, through additional data, new lab results, and so forth. Planned timeframes serve to facilitate the progression of the scenario and ensure that there is a reasonable time to achieve the objectives. The other section of the scenario is the identification of critical actions and performance measures that must be documented in the template of the scenario. It is required to evaluate achievement of scenario objectives. Each measure should be evidence-based. Use of subject matter experts will strengthen validity of the simulation scenario and critical performance measures. What about the fidelity of the scenario? Various types of fidelity should be considered to create the required perception of realism that will allow learners to engage in a relevant manner. The design of the simulation is enhanced through attention to physical or environmental, conceptual, and psychological aspects of fidelity in order to contribute to the attainment of the objectives. First, the physical fidelity relates to how realistically the physical context of the simulation-based activity replicates the actual environment in which the situation would occur in real life. Physical fidelity includes such factors as the standardized patient, simulator mannequin, embedded participant, environment equipment, and the related box. For the conceptual fidelity, it ensures that all elements of the scenario relate to each other in a realistic way, so that the case makes sense as a whole to the learner. Example, vital signs are consistent with the diagnosis. To maximize conceptual fidelity, scenarios should be reviewed as subject matter experts and pilot tested before use with learners. Regarding the psychological fidelity, it is maximized when the simulation environment mimics contextual elements found in clinical environments. For example, an active voice for the patient to allow realistic conversation, noise and lighting typically associated with the clinical setting, distraction, family members, other healthcare team members. Psychological fidelity works synergistically with physical and conceptual fidelity to promote learner engagement. I would end this chapter of fidelity by emphasizing one thing. It is important to reiterate that the distinction between fidelity and modality or technology. These terms are independent of one another. High technology doesn't necessarily equate to high fidelity, and any single modality, mannequin task trainer, may or may not be high fidelity. Not every simulation requires the highest fidelity of realism. The degree of fidelity and its implementation need to be determined through the examination of several factors that may include, but are not limited to, learner level, learning objective, desired learning outcomes, available time and resources, available equipment. And and we came to the 10th criterion, the facilitator and the facilitative approach. The facilitative approach is determined in the design phase. The specific facilitation method selected should be participant-centered and driven by the objectives, participants' knowledge, level of experience, and the expected outcomes. The level of facilitator involvement is inversely proportional to the participant knowledge and experience. The facilitative approach should be consistent among facilitators for each scenario, case, or SBE. It's crucial in the scenarios for assessments. For the most effective outcomes, facilitators should receive formal training in simulation-based pedagogy. If the plan is to have more than one facilitator, applying an structured approach to pre-plan certain aspects of the pre-briefing and the debriefing session. Facilitators should incorporate evidence-based components of cultural diversity within the simulation design for scenarios. Predetermine the delivery of cues as part of the facilitation planning to be delivered during the simulation activity. Facilitators should be aware and mindful of the learner's diverse cultural differences, values, and responsibilities, and consider that during the simulation during the simulation design phase. Facilitators should refer to the healthcare simulation code of ethics with respect to confidentiality, mutual respect, and creating a safe educational environment. And finally, the debriefing. After the briefing and the scenario itself, the last phase is the debriefing or the feedback. Using a planned debriefing or feedback session or reflective exercise enriches learning and contributes to the consistency of the scenario for learners and facilitators. Effective debriefing is enhanced by adequate preparation of the facilitator, who should have formal training in debriefing techniques. The debriefing allows, we have to allow enough time for debriefing sessions because it is the most important section of the scenario. Or it is a very important section in the scenario. Simulation without debriefing solidifies rather than corrects mistakes and misconceptions. Debriefing is a guided period of self-reflection that should take approximately twice as much time as the scenario itself. The debriefing facilitator employs structured debriefing framework and must have observed the simulation scenario before the debriefing, of course. The instructor reviews, emphasizes, and provides feedback covering the goal and objectives. The objective describing the expected outcomes of the scenario serve as a guide to the debriefing. Identifying the most appropriate debriefing is a part of the design phase. The debriefing and feedback are different, but both are critical elements and should be structured using best practices. In the case of skill-based activity, debriefing may be replaced by feedback, so the participants are guided to further improve or confirm their practice. 12. Evaluation. To ensure quality and effectiveness, we must develop during the phase design and not until the implementation of the scenario. We have to develop during the phase design a plan for evaluation of the learner in one hand and of the simulation-based experience in the other hand to determine the quality or effectiveness of the simulation session. We have to select a valid and reliable tool to measure expected learner outcomes. Regarding the evaluation of the learner, we have to be sure that the participants understand the method of assessment. Is it formative, summative, and or high stakes? This information must be given to the participants before or at the onset of the simulation, and not at the end. Learner evaluation may be formative, summative, or at high stakes. The assessment method used are observation-based checklists, rubrics, reflections, and technological feedback from haptic devices, and so forth. For the second evaluation, the evaluation of the simulation-based experience. The process evaluation should concern all the elements involved in the session. Must concern the learners, the facilitator and support team, the scenario, and the facility, and others, and all these stakeholders involved in the scenario. The evaluation includes input from participants, the learners, peer clinicians and educators, and simulation program staff, and simulation program faculty and staff. These process evaluation data are used for continuous quality improvement. The last criterion is the pilot testing of the session. On completion of the design and before its full implementation, the entire session should be pilot tested to ensure it accomplishes what is intended, it meets objectives, and is effective when used with learners. We have to select a participant similar to the target learner group for the optimal test environment. We have to select any tool, checklist, and other measures to assess for validity and to ensure consistency and reliability by expert review, integrated reliability. Any confusing, missing, or underdeveloped elements of the scenario can be identified during the pilot testing and addressed before the actual simulation encounter. We have to recognize that it may not always be possible to pilot test simulation-based experiences prior to facilitation, for example, with limits to time and resources. And finally, we can use templates ready to use, and we can select some templates to guide the evidence-based design and standardize the design process. A sample of template resources is available in the literature. There is a lot of template resources. I show here some. Most North American simulation centers also offer online scenarios. Here are just a few examples. To conclude, SBEs of simulation-based experiences, similar to all educational experiences, should be deliberately planned, guided by needs assessment and objectives, deliberated with simulation and content experts, tested before implementation, and evaluated after implementation. These standard criteria provide guidance for educators by outlining the many factors and elements to be considered when designing a simulation scenario to optimize the participant learning outcome and to ensure the effectiveness, quality, and validity of such learning experience based on current best practice. For the last messages, we have to focus on identifying learning objectives, of labeling it appropriately, to choose the right simulator and the right equipment. I will say keep it simple without pitfalls for the learners. It is not the objective of the simulation session. Either in the education field or in the assessment field. Simulation scenario design is best completed stepwise, focusing on the intended learners, objectives, gaps to fill, level of fidelity, feedback, and didactics. Healthcare educators and simulationists must work together to create high quality, well-rounded, detailed simulation scenarios. Dry runs and rehearsals are key to success. And thank you.
Thank you, Dr. Yamama. Any question from the participant? Please start. I have one question, Dr. Yamama, about the case scenarios. When we write the case scenarios, and you mentioned we're supposed to do a pilot, and then we evaluate the pilot depends to the.
Sorry, I didn't hear.
You mentioned about how to write the case scenarios depends to the department or the specialist, and you say you have to try it before, like similar like a pilot before. Is that necessary for each scenario? Supposed to do a pilot before, or enough if we try in the first time and we evaluate the programs and get the outcome?
Is it for the rehearsals? You are talking about the rehearsals?
I'm talking about the slide. When you talk about the pilot, you say you have to try your own scenarios when you write it down, and make sure we plan it in good way. And
yes.
One of the success thing, you have to do a pilot before we do the programs and get the outcome from that. My question is that necessary, or we can start the programs and get the outcome after that?
Sure, as I said, it's not necessary. It's preferable, but it's not necessary. It's if we need it before the program, it will give us some cues to correct some mistakes or to address some things. But it's not necessary, as I'm showing in the slide. When we have limited time or limited resources, we can make the start with the simulation and collect the input from the stakeholders after the session.
Okay. What about if we doing a scenarios, but during the operate programs, let's say in the scenarios is writing down the patient, it will bleeding or something, but the participant act and act similar like the patient will die. During that times, if something happened, it's not written in the scenarios, what's supposed to be we do?
We have in the storyboarding. I can't cover all this aspects of the design of the scenario, but in the storyboarding we have to put a branch point when for each action from the learner and the reaction. What we do if the learner acts as this. The storyboarding must be as complete as possible to think about all the outcomes possible, the possible outcomes, and all the possible actions from the learners.
Thank you, Doctora. It's clear. Thank you so much. Thank you for joining us in Saudi Commission Simulation Healthcare Simulation. And we're glad to have you in our programs. And thank you for giving us this amazing lectures. And I would like to thank all the participants who join us in these programs, and remind them about the Saudi simulation programs during these weeks. Register in our programs. It's free programs, and have a good time. Thank you so much for all.
Thank you so much.
Thank you.